Good morning, everybody. Today I'm going to talk about chronic laryngitis. Before going into chronic laryngitis, we'll have a just look into the basic normal anatomy of the larynx. This is the laryngeal picture as seen from an indirect laryngoscopy, where you can see this is the epiglottis, this is the vocal fold, this being the arytenoids, and then this is the posterior part, this is the anterior part, the pyriform sinus. Now coming to the anatomy of the vocal fold, if you look into the anatomy, it has basically made up of the vocalis muscle in the bulk. Then it has a layer of lamina propria, which is a superficial layer. Then there's an elastic conus deep layer. So this lamina propria has a superficial layer and a deep layer. The deep layer has the elastic conus, whereas the superficial layer is the lamina propria. Then it has an epithelium covering on the top. So basically, when we talk about the vocal fold, so vocal fold cover is the epithelium, the lamina propria, which is the superficial layer. Okay, this much is called the vocal fold cover. Next comes the vocal ligament, that is the intermediate and deep layer of the lamina propria. The vocal fold body consists of the thyroarytenoid muscle complex. So the vocal fold cover, the ligament, and the body. Now, coming to the inflammatory disorders of the larynx, we have the acute infections, chronic infections, laryngeal edema, and LPRD. But we will be today discussing regarding the chronic laryngitis. Okay, we will be talking about so chronic laryngitis refers to an inflammatory process that determines irreversible alteration to the laryngeal mucosa. This is a reactive and reparative process of the larynx, represent the main pathogenetic factor which can persist even when the causative stimulus ends. Non-specific, there is no specific detectable cause. Can be chronic hyperemic, chronic hypertrophic, atrophic, or pachydermia, that is the contact granuloma or an ulcer. So basically this is a non-specific type of we are dividing the chronic laryngitis into non-specific and specific. In specific, we talk about chronic granulomatous lesions like tuberculosis, syphilis, scleroma, leprosy, fungal, and amyloidosis. In chronic hyperemic laryngitis, there is a diffuse inflammatory condition involving the whole larynx, particularly the true and the false vocal cords. Causes being recurrent acute laryngitis, incompletely resolved acute laryngitis more than 3 weeks, chronic infection in the vicinity, that is sinusitis, tonsillitis, bad orodontal hygiene, or chronic bronchitis. Occupational factors being dust and fumes, smoking and alcohol, voice abuse, and GERD. We have the dull and the appearance of the vocal cords, its rounding of its edges. Coming to the treatment, you eliminate the cause of the infection or the irritating factors. You give a complete voice rest, observe a proper vocal hygiene, and medicated steam inhalation helps. Expectoration depends, like expectorants we give if there is person has chronic coughing, you know. And the there's hyperplasia. So what exactly has happened is there's an there's an hypertrophy of the epithelium that has happened, Rinke's edema, or there's a polypoidal growth on the vocal fold. And with this, you can see with the polypoidal growth, this is edematous. Now, coming to Rinke's edema, we have causes such as hyperemic chronic laryngitis, laryngoscopy, in laryngoscopy, you see laryngeal mucosa is thickened and dusky red in color. Vocal cords are red and swollen, edges are loose, and there's a sharp demarcation. In dysphonia plicoventricularis, false vocal cords are swollen and may cover the true vocal cords. Coming to the treatment, you have a conservative treatment or a surgical treatment. Surgical means you have to strip off the edematous mucosa with micro scissors, this ablation with laser, and one side done at a time to prevent the web formation. Coming to atrophic laryngitis, it is common in women associated with atrophic rhinitis. So, atrophic laryngitis presents with laryngitis sicca. Now, exact cause is not known. Hormonal imbalance, dietary deficiency, and autoimmune disorders. Bacillus ozeanae can cause secondary infection in atrophic laryngitis. Clinical features are hoarseness of the voice, dry irritating cough, dyspnea due to crus. Laryngoscopy, you see laryngeal mucosa is dry and atrophic. Treatment, basically primary condition, so you can treat the atrophic rhinitis. So atrophic laryngitis also improves. Steam inhalation helps. 25% glucose in glycerin sprays can prevent the dryness being happening. Now expectorants containing iodines to loosen this crust. Because of this dryness which is happening, there's so many crusting and crust formed which has to be removed. We'll talk about tuberculous laryngitis, which is secondary to pulmonary tuberculosis. It is common in adult males. It can inoculation can be because of bronchogenic or a hematogenous route. Bronchogenic route is affects the posterior larynx basically, that is the interarytenoid region, submucosal tubercles and granulomas. Hematogenous route may basically have multiple painful ulcers in larynx and pharynx. Clinical features, there is hoarseness of the voice, painful ulcers which are referred otalgia, odynophagia will be present. In laryngoscopy, we can see pale granulations in the interarytenoid region. The stages of the laryngeal TB, in stage 1 we have exudation and hyperemia in the subepithelial layers. In stage 2 we have mononuclear round cell infiltration of the subepithelial layers causing pseudoedema. Stage 3 we have tubercle formation, that is granuloma with epithelioid cells and Langerhans giant cells with caseating necrosis. Stage 4 there is ulceration, there is shadow ulcers with undermined edges involving arytenoids and epiglottis. And because of this, it looks like a moth eaten or a mouse nibbled appearance. Cicatrization is when the ulcers heal with fibrosis. Now, ulcers of the vocal cords, basically, yeah, because of its multiple ulcers, it looks like mouse has nibbled into it, so it's a mouse nibbled appearance. The swelling of the false vocal cords and aryepiglottic folds. There's something called the epiglottis looks huge, that's why it looks like a turban epiglottis. Investigations, you have to get an X-ray chest and a sputum has to be sent for AFP and a biopsy has to be indicated. And if it's found positive, treatment is as per pulmonary tuberculosis. We'll talk about local nodules, also known as singer's nodules. It's common in voice misusers, like teachers most commonly, singers, preachers, and vendors. Basically, because of constant loud voice or because they keep screaming in high pitch, so there is a vocal trauma that happens, and there's a submucosal hemorrhage that happens, and that undergoes fibrosis and hyalinization. Basically happens at the junction of the anterior one third and the posterior two third, which is the place where the subjects to maximum trauma. Clinical features, this history of voice abuse, hoarseness will be present, vocal fatigue. In laryngoscopy, we can see symmetrical nodular pinkish or grey masses at the junction of anterior one third and posterior two third of the true vocal cords. If you look at into this picture, you can see there's a bulge here. See, this is the anterior one third, this is the posterior two third. So this is a bulge. This is basically the vocal nodule that has happened. Typically, you can see this nodule. This is a magnified image of the nodule. Same thing, same picture. This is a bigger size, you can see. Treatment is basically conservative. Like you have to tell the patient to have absolute voice rest. Speech therapy will help the proper use of voice. There should be no shouting, no whispering. And if he's a singer or a teacher, we should ask them to change their profession because that is the only treatment. Surgically, we can do an MLS, that is microlaryngoscopy, or a laser and excise these nodules. Thank you.